welcome. This is something that the Bootcamp always has, just a little ACO 101 data, because you're going to be getting a whole plethora of information. And for everybody else, if you've been on this webinar, I'm doing a refresher, but I'm also adding with Maria a whole bunch more information because the data is ever evolving and CMS is always updating everything. If you're not familiar with the ACO spotlights, or even NAACOS does a really great job with their newsletter of telling you what's coming, what's new, and the like. So I think that's really important to have this in your pocket. Use the presentation with your groups just so that they get a feel for what's available, especially new hires even. So let's talk about Maria and myself for half a second, just so you get some background. But speaking today is Maria Nikol. She's our senior business consultant at Salient and has over 12 years of experience in healthcare operations and strategy. And her specializations include process and the application of emerging models of healthcare delivery. And then as for myself, I'm Amy Kotch. I'm the principal business consultant and team lead. And my team's main focus is to act as a liaison between our clients, such as yourselves, and our developers of the solution. I have over 7 years of experience in the value-based payment arrangement world. I primarily work with ACOs and MSOs, and I'm working with them in their operations and working to transition some of their workflows to address the needs of their patients to support the triple aim. So today we're going to discuss the various data sources you're going to need to obtain. And a lot of them were addressed in the previous presentation, which makes a lot of sense. And then we're going to talk about the process of you obtaining that information, organizing it, enriching it, and then putting it in a usable form so that you can actually do continuous process improvement, which is the foundation of the ACO model. And we'll show you that through a few use cases. So we're going to start with data sources. This slide is intentionally overwhelming. It's because there's a myriad of data sources. I mean, they've been listed on the presentations. And I kind of think that the ACO is structured in a way that's best suited to bring them all under one roof. You're an ACO, you could be an independent group of all independent docs. You can be a part of an employee model with a hospital, or you can have some sort of combination. Mary Butler spoke from CCPM. They're all FQHCs with some community hospitals. There's like a whole bunch of variations that your organization can be, but the ACO structure enables you guys to bring a lot of this information under one roof and help some of your other organizations that you might be affiliated with to piece together that information. So on the left-hand side of your screen is a list of CMS sources. The first 6 are bolded because those are provided to you by CMS on the ACO Hub. So those are going to be available to you on a regular basis. They come in different cadences, and the ACO Spotlight will tell you when the next release is going to be. And they change all the time. So for example, on the attribution files, we now have a new tab that tells you about COVID episodes and which patients are a part of that COVID episode, so you know whose data is being removed when they do the calculations. You have your expenditure and utilization files. There's a Q in front of it, an M and an A. That stands for quarterly, monthly, annual. For those next gens on the call, you get it monthly and everyone else gets it quarterly and an annual. That's going to give you a whole chunk of information. And I want to point out that the footnotes are absolutely key in understanding the whole thing. So if you don't read footnotes, you're missing out on a lot of information. And then you have your benchmark files that you need to look at and know what you're being measured against. So it's really important to really dive deeply into what's being provided to you. And then you have information on the right-hand side of the screen. And that is a bunch of other sources you might want to consider. Of course, if you have multiple contracts, Medicare Advantage, commercial ACO, Medicaid, and the like, you'll want to bring that information ideally into one system so you can compare apples to apples. You also have your EMR and EHR data. And like mentioned before, it's all use case driven. So all these other data sources can be overwhelming. You see these lists and you're like, I want to pull it all. But if you don't have a bottom line use case of what you're trying to change, then it's hard to figure out what you want to pull in. I think our chief medical officer wrote a blog that was called Data Everywhere and Not a Drop to Drink, something like that, using all those phrases. If you're just overwhelmed, you're not going to make a change. So figure out exactly what those use cases are, and that'll help you decipher what kind of information you need to pull in. Clinical data is needed for your quality metrics. So of course, you're going to want to seek that out. And we talked briefly about HIEs, health information exchanges. They vary from state to state. So I live in Florida, despite me wearing a sweater. I know that looks a little weird, but in Florida, it's just admission, discharge, and transfer files, so ADTs. But Maria is up in Maryland, and they have skilled nursing facility information. It's a little bit more robust. I think some HIEs have pharmaceutical data in them. So it really varies in what you can pull in. As for care management, scheduling, and billing, that's like a whole nother slew of information you may want and have under the same system, because you're able to, like what we talked about with patient matching, if you can follow a patient across their contract with their clinical information, their claims information, and even some written documentation in care management, you get a better picture of what you're looking at. So that is a great piece of information to pull in. And then lastly, we spoke about social determinants of health very briefly on the last call. It comes in a number of forms, and we've worked with it in survey form. And also you could pull it from some credit unions, although that can be on the more expensive side. But again, it's all business case driven. So what exactly are you using that information for to drive the change? So with that, that brings us to our second poll question, which is how many of these sources listed are you using? 1 to 4, 5 to 10, 11 to 15, 16 plus?
All right, the results are trickling in. We have about 15% voted. Let's hopefully get up into that 60s, 70s mark, maybe higher, and then I'll pause the poll. All right, looks like it's steadied out. I'm going to go ahead and end and share results with everybody.
Okay, so around 5 to 10, and those first 6 that are bolded are provided to you, so a little bit meld together. It's really important to get those use cases. So the number of sources you're pulling in doesn't really matter as long as you're able to address your ultimate needs. And this is really great information to understand. I think, more isn't necessarily more, but as long as you're able to compile it all and get it in one place so that you can make the right decisions is absolutely paramount. All right. So the next 2 slides are screenshots from the ACO Hub. If you haven't logged in here or you don't really know anything about it, usually maybe it's like 1 or 2 people have login access. I think it's important to just know what exists here. They give you a lot of different resources just from CMS. So what's shown here is the bottom right picture is of your CCLFs. This is where you actually manually download your claims files that appear on a monthly basis. And then you also have other reports that are available to you. You get exclusion files of patients who have opted out of data sharing. You have your attribution files and other reports that are all available to you in this data hub. And then on the next slide, I'm showing you a screenshot of just some reports that are already built in. You can see a listing of your providers and suppliers and your affiliates. You can take a look at your final report. So there are things that are already built in here. And what's nice is we're able to kind of pull that out into our own system so you can compare it to the fleshed out claims and see where it matches. That's also something nice to do. We find that with a lot of commercial payers, they give you summary reports, but you haven't found a way yet to take the claims and actually match it to those summary reports. And that's what we're doing with the CMS data here. And we're doing that with some of the commercial payers as well. So it's exciting to actually empower the provider organizations themselves with the information. So moving into the next slide, we're going to talk about obtaining your information, organizing it, and enriching it, because everything comes in columns and rows, but how do you make sense of it all? That's kind of the real importance of this. And on the next slide, the key thing I wanted to note here was security. Patient information is protected under HIPAA, and it is extremely important that data is encrypted at all three of these locations during the transfer of the information, while it's in storage, and while it's being consumed. And those are three different locations. So it's important that you're doing that. Salient has gone so far as to have an information security officer, and we also get third-party audited via SOC. So we have a SOC 2 type 2 certification there. And I think that's really important when you're making a decision whether to even build or buy, like that discussion we just had, is how much time and financially equipped you are to ensuring security of patient data. So I just wanted to kind of put that little piece in there, because that is a big part of what we do. And we are constantly auditing our system. So the next poll question is, how many of you actually have information security officers on staff or staffing who are primarily involved in the security of your data?
All right, the results are coming in fast. We are around 1%. And I think you will be surprised by the response we have, but I won't spoil it so not to bias this poll. All right, I think we've studied out.
All right, a lot of you do have security officers, and I think that's great. I feel like we have a different healthcare organization in the news, whether it be a vendor or provider or someone who's had a data breach, and it's just the world we live in. So it's absolutely important to have this. All right, let's move into obtaining that information. Oh, how do we want to address the question? Should we do them on the fly or at the end of the call? Maybe at the end.
Yeah, I think you should decide if it's easy to take on right now or save them. Either way is fine.
We'll save all the questions for the end. I think that'll be a little bit easier. And maybe we answer them as we go along. All right, so let's talk about obtaining data. This was mentioned on the prior call as well, but just a little bit more in depth. Templates, absolutely important to get interoperability, to translate from one system to another. You need to have a template. Your data can be in a lot of different structures, and it has to come down to how do we normalize and templatize it so it can go from one system to another. That's how we bridge the gap of all of our siloed information. So listed are just examples. We brought up QRDAs. 1 and 3, those are templates. You have your electronic clinical quality measures, your ECQMs, CCDAs, those are all, EHR formats. HL7 FHIR is your common one that's being built upon. So I think that's great that there's an initiative out there to get more in that method, because HIEs, EMRs, ADTs are all using that type of method. So I think it's really important that we get there, because we won't have interoperability if we don't templatize the information so that it can be exchanged. The next piece of it has to do with transferring your information. So to securely transfer the information, you're going to do it in a number of ways. I brought up the most common ones. One is that direct access to the ACO site, right? So you're logging in, you have your own login, that's protected, you're downloading that information, and hopefully you're storing it in a secure location. What we do with a lot of our clients is we either set up a secure file transfer protocol where they download the information or they obtain it some way, and then they send it over to us in this secure manner. Some clients give us direct access to the portal. That's another way. And then there's the API. And I want to bring up the API because I think it's great that CMS is pushing it. All of your CCLF data is available via this method, and it's actually coming weekly instead of monthly, which is very exciting. So we have been building that out, and that enables machine-to-machine communication. So it's automatic download of that information and pushing it onto the platform. And that removes all that human error that could happen. You know, if you download a document or you forget to download something because it was posted really late, you know, CMS 4 o'clock on a Friday, you know, they love that type of thing. So if you forget to do something, that kind of removes the whole human error aspect, or even computer error. You know, you downloaded something and it stopped midway and you forgot to do something else. So the API gives you that ability to not have to worry about that information. So those are some data transfer methods that you would consider. All right, then there's the storing of the information. So you need to warehouse that information and pull from it. So it's what we do is we have all of the different data sources. We pull them into a system where we templatize and normalize it, and then we warehouse it so that it can be tapped into from a number of interfacing systems. And there is a lot of encryption around where this information is stored. There are HIPAA rules around it, and it's important to understand that you need your information in one place, because if you're pulling from a number of different places, things will get lost, connections will fail, and it's much easier when it's all in one location. So when it's in this one location, you want it to really show you information that has been templatized and normalized. And this is just an example of a few different types of payers. And what we do on the back end to normalize the information, we basically create a master template. And you can see some data fields under MSSP ACO, like claim payment amount, the NPI, your claim counts, pay to provider. There's a million other rows there. And then we look to see what matches across the other payers. So we kind of do like a translation from one payer to another to see which fields actually pull in the same information, so you can compare it in an apples to apples way. And sometimes there's net new items. You know, a payer might have a really unique measure, but sometimes there are things that really match and just have different titles. Sometimes, although it is rare for a commercial payer to have something that Medicare doesn't have, we found that the Medicare ACO claims data is way more robust than others. And then, of course, all the clinical data is entirely different, but there is a way to match it up via a patient key, so you can say which patient is attributed to what information. So that's what we're doing in our data warehouse. There are needs for transforming your information. So we call these enhancements or enrichments to the data. We don't speak in terms typically of claim payment amounts. You know, we're not talking in millions of dollars. We typically talk in a PMPM or a PMPY. So you need to apply mathematics to some of the data that you're provided with, such as adding claim payment amount and member months to get that information. Or what we do is we create a visit and an episode. So in order to group them together, you need to know claim from and through dates, plus the pay to providers to know exactly where they're going. Are they staying in a skilled nursing facility continuously, et cetera. To calculate risk scores, we're using diagnoses and demographics for the HCC methodology, plus their tables that are being provided. And attribution. Attribution comes on a quarterly basis, but you can decipher patient attribution even so much as on a monthly basis if you're looking at the beneficiary claims and you apply CMS's two-step attribution logic. So you're able to do these things and enrich your data and actually make use of it so that you can make those decisions that you need to. All right, then there's data visualization, which wasn't really touched upon on the last presentation. In order to use the information, you have to be able to see it some way. So there are companies out there like Tableau and Click that'll read a warehouse, and Salient has we have our own proprietary warehouse and visualizations. But you need ways to look at your information, whether it's in a table format or if it's in graphical view. On the next slide, I have some screenshots of what different systems look like. These are two of ours. On the left-hand side is like what a dashboard would look like. So out of the box, something pre-created for ACOs, looking at your spend, your annual wellness visit completion, your risk scores, and your attributed lives. Something that's really out of the box, easy to visualize with a lot of graphics, trends, pie charts, and the like, things that can be used for board meetings, etc. And then you might really be more interested in something that's like a blank canvas, especially for data analysts who want to create their own analytics. You want something that's more of a mining tool. So we have our data mining tool, Salient Interactive Miner, on the bottom right, and it's showing a scattergram so that you can pick out outliers. Right here, I think we're showing spend and risk. So who are your outliers for spend and risk? So there's different ways to visualize the information so you can actually figure out what's my baseline and am I improving or not? So I think that leads us to the last poll question, which is how many of you are doing your data analytics in-house with a vendor or some sort of combination?
All right, the results are rolling in fast. All right, we have steadied out. I'm going to go ahead and end the poll and share the results.
Yes, I figured as much, some sort of combination, and I think that makes a lot of sense. You need to use a vendor when you need to, and sometimes it's not scalable, sometimes it absolutely is. So I think knowing this information is really good, that sometimes it is a piecemealed approach, and ultimately we're working to get to the same place. So with that, I'm going to hand it over to Maria, who's going to talk about the continuous process improvement cycle and how all this data kind of leads to the how, which is how are you going to actually make those decisions?
All right, thank you, Amy. So the continuous process improvement cycle is really at the forefront of value-based care. And as organizations look to succeed in their value-based contracts, no matter if it's a commercial, Medicare, Medicaid, or a MA contract, the process is going to be exactly the same. First, you're going to view your baseline data, and this may present additional challenges if you have multiple contracts, but not a single platform to do it in. Second, you'll want to identify areas of improvement, and these areas of improvement will need to yield the highest ROI with the lowest level of effort. You may want to identify which initiatives the entire organization will want to do, as well as identifying areas of opportunity by both practice and providers. And third, you'll implement the initiatives to help reduce costs and improve quality to achieve overall shared savings. Next, you'll revisit the data to see if that change has actually been made. Now, if the desired change had been made, you're going to continue the initiative. If the desired change had not been made, you're going to identify a new initiative to implement. So if the desired change was not made, the new initiative was implemented, you're going to revisit the data to see what you could be doing differently. So as you continue to improve, you're going to revisit the cycle with each opportunity. So let's go ahead and take a look at an example. So first, you're going to review the baseline data to identify those areas of opportunity. This is mostly done with a scorecard. So this is a sample scorecard that's available in the Salient solution, and this presents some demo data. So first, you'll want to identify the areas that are highlighted in red that really require a low level of effort, a high ROI with an immediate incentive. So for example, perhaps the organization has a really low annual wellness visit completion rate that correlates to low quality scores, and it's really continuing to decrease as it's noted in red. So let's say they're currently at 12%. The organization may also have a really high ER visit rate at let's say 800 per 1,000, and that's increased 40% from the prior year. So we're going to go ahead and design some initiatives around quality improvement and ER visit rates. So as you may already be aware, there are significant changes to quality reporting that are coming soon. And it's imperative for organizations to follow the process that we had just reviewed to obtain, organize, and enrich the data. The data sources that will need to be aggregated will be EMR data and claims data, depending on what type of measure it is. Additionally, the complexity increases as you add more and more EMRs. So even if your organization is on the same type of EMR, but you have different versions of it, you're going to need to figure out how to aggregate this data. You're going to need to identify how you're going to collect it, where it's going to be stored, and how to consume it in a usable fashion. Instead of just a sampling methodology, you're going to need to aggregate it across all payers and all patients and identify process improvement methodologies to ensure that you're consistently closing care gaps for your patients. So another initiative that's probably on the front of everybody's mind is using data to evaluate emergency room utilization. United Healthcare had recently announced and then subsequently retracted their policy around reimbursements for non-emergent emergency room visits. However, it's still probably an initiative that may be good to implement to reduce the total cost of care and ensure patients are getting the right care at the right time. You may want to evaluate your claims data to determine whether those visits are emergent or non-emergent. Now, there's several well-known cohorting methodologies to group these visits. For example, NYU had done a study that identifies the 4 groups of ER visit types. So an organization may evaluate whether the visits are primary care treatable, emergent, or non-emergent. And then once you've identified that a large group of visits are actually preventable, you're going to implement initiatives that provide increased access to care, including, but of course not limited to, updating office hours, partnering with urgent care centers, updating voicemails, and providing increased patient education. And additionally, your practice may want to also identify your frequent flyers. In other words, those patients that are going 3 or more times in 6 months, and specifically target those educational campaigns towards them. I'll also point out that Salient maintains a library of resources for our clients where they might find helpful tools to help implement those initiatives. All right, so now that you've implemented the initiatives, it's important to identify whether they had the desired outcomes. Now, if they did, you'll want to identify new areas of opportunity and repeat the process. For example, your emergency room visits had a significant decrease, and your annual wellness visit rate and quality improvement initiatives have really worked. Now, if they did not, you'll want to identify what didn't work, redesign those initiatives, repeat the implementations, and see if the changes had made a difference in the rates. Now, I also recommend following this process not just at the organizational level, but also at the provider and practice levels. So let's say that the organization isn't doing well on their annual wellness visits, but there's a practice or provider that's actually achieving their 70% completion rate. Now, in this instance, you could definitely use them as a physician champion or a practice champion. And this practice might not want to improve their annual wellness visit rate. They might want to focus on something else that will yield a higher impact. All right, so with that, I'm going to go ahead and pass it back to Amy to close out this portion of the presentation.
Thanks, Maria. I think you did a nice job of showing how you actually use the information to drive the change and how CPI, continuous process improvement, is really the foundation of everything. So it makes sense to have that combination of doing things in-house and having a vendor, because it's that what, how, why, you're kind of solving for all those pieces, and you need different people to help along the way. And ideally, this is something that you want to do at scale because we're all moving towards value-based contracting, across a number of methods. So you're not just in the ACO, but you'll probably be involved in Medicare Advantage and in commercial plans and the like. And you're going to need to figure out a way to get it all in one place, normalize it, see it, and then make some of those changes in your organization to really achieve that triple aim. So I think with that, we're going to hand it over to Jen, unless there are specific questions we should answer.
Well, great. Let me, a couple questions from the chat. Do you know the current availability of the interactive reports previously on portal.cms.gov? So in the chat, there's a very specific question, and I don't know if you want to answer that offline or if you know the answer off the top of your head.
Yeah, I can probably give you information. I'll send it over to you, Nikol. And I can answer that offline.
Okay, great. And then how many resources, level of expertise do you leverage for in-house tools? Again, you may want to respond directly to that question. Amy, does that sound good? You'll address that in the chat. And then a question just in, how do you manage variation in measures across different payers? Anything you'd like to share on that? That sounds like a nice cross-cutting theme.
Yeah. So we work really closely with our clients to actually kind of dive into some of those measures that are questionable. Some of them are very obvious, it aligns from one to another, good. But in cases where they don't really align, we either have documentation that says, Humana is specifically looking at this, and that's when you look at this measure, you have to note that data nuance. But sometimes we could actually calculate it and we go back and forth with the payer to try to normalize it. So I think there's a number of different methods, or we just create a new field. So for example, United has their own risk scoring methodology for their commercial payers. It would just be a UHC risk score, and you put that adjacent to your HCC scores, and you can't really compare apples to apples there, but you can for your MA and some of your other payers who are using the same methodologies. So it's important to work closely with the payer and also ultimately as a vendor to work with the client to say, what exactly do you need to see here? What needs to match? And if it doesn't, is there something else we could use? Or do we need to just create something that's net new? Because you need all the information in one place. I hope that addresses it. Maria, I don't know if you want to add anything there.
No, I think that covered it.
Awesome. Well, thank you both. Don't go anywhere. I'm sure there are going to be more questions, but I'd love to